Well, good afternoon, everybody. It is a great pleasure to share these guidelines with all of you. These are guidelines that we all tend to read very carefully because this is what we do every day in our work. So thank you for joining. Here, I'm not going to go over all of these in detail, but these are our learning objectives. And I think the most important thing that we would like to do is to define what are the new updates on chamber quantitation guidelines of the right and left ventricle. In the year 2005, I had the great opportunity to chair the chamber quantification writing group on behalf of the American Society of Echo and the European Association of Echocardiography, as it was called at the time. And these guidelines became, I think, very important, and this is sort of seen in this next slide. These guidelines of the American Society of Echo were cited 5,500 times. So just to put it into perspective, a very popular manuscript will probably have around 100 citations. So for the last 10 years, this was the most highly cited manuscript every year of the American Society of Echo Journal. And moreover, for many of these years, this document was more highly cited than all the other documents published in our journal during that year. Another example of how or why this is important is you can see that these guidelines were translated into numerous languages and published in the respective societies, and you can see examples in Chinese, in French, and in Spanish. These posters were also translated into many languages, and we also had one of our first apps for our phone that incorporated the guidelines. So you might ask yourself, the question is, why did we need to repeat these highly popular guidelines 10 years after the initial ones? And I think that this can be nicely summarized by the fact that since the last guidelines 10 years ago, two major things have happened in echocardiography. One is the advent of strain or deformation imaging, and the other one is the advent of real-time three-dimensional echocardiography. These have really changed the way in which we practice echocardiography. Another very important thing to take into consideration is that in the last document, a lot of these normal values were obtained by a consensus of experts. We called people at different labs and asked what are the normal values, and then we averaged them, and that is how many of these numbers came about. In this document, we have obtained from many very uninterested and nice people databases, and I'll talk to you about this in a minute. And we have averaged all of these databases from which we obtained the normal values, many times on thousands and thousands of patients. So I would like to also take this opportunity to thank Dr. Badano from Europe, who was the co-chair of this writing group, and of course my colleague, Dr. Victor Moravi, which was instrumental in getting all of this done. This was a true collaboration between the American Society of Echo and the European Society of Cardiovascular Imaging. One of the important new things is that as these old guidelines came about, then we saw guidelines on diastolic function and right ventricular and so on. And as these guidelines popped up, there were certain discrepancies between guidelines. So we hope with this new document to eliminate some of these guidelines. So this here is the new document that was published last month in the Journal of the American Society of Echocardiography. So, when you think about it, this is, I think, something that is also extremely interesting, is that in the previous guidelines, we, for every parameter, provided cutoff values of severity. By that I mean normal, mild, moderate, and severe. And these were done in a sort of relatively arbitrary way. So if you want to improve the statistics, you can see that these cutoff values can be based on different sort of parameters. One parameter would be to use cutoffs based on standard deviation. That would be, to get cutoffs that are below or above a reference limit derived from a group of healthy people. The advantage of using a standard deviation is that these data exist for most echocardiographic parameters. However, using standard deviations is fundamentally flawed. First, not all of the echocardiographic parameters have a normal distribution, a Gaussian distribution, even in a normal population. Second, even if a particular parameter is normally distributed in normal subjects, most echocardiographic parameters when measured in the general population have an asymmetric distribution, usually going in one direction, either abnormally large for size or abnormally low for function parameters. Another way of getting these cutoff values would be to use percentile values. For example, the 95% or 99th percentile values of measurements obtained from a population that includes both healthy people and those with disease. Although these data would still not be normally distributed, they would account for the asymmetric distribution in the range of abnormality present within a normal population. The major problem with these percentile values is they do not exist in echocardiography. An ideal approach would be to use cutoffs based on outcomes or prognosis. This would be obviously preferred, but we have only sufficient data for ejection fraction, for left atrial volumes, a little bit for LV mass. So this approach also has a limitation. Then the second thing is, how do we all define risk? What is the best definition of risk? And the cutoff suggested for the same parameters may vary broadly for different risks. If you measure left atrium in an athlete or in a normal, cutoffs would be different, very, very different. So the other possibility would be what we did in the past, which used cutoffs based on experience consensus. So as you can see, there is no true great way of obtaining these cutoff values. So in this document, we only will present cutoff values for certain parameters, such as ejection fraction, left atrial size, and LV mass. For all the other parameters, the committee decided to provide you with a normal range, and then how much that range deviates from normality, every lab will have to decide what adjective you want to place behind it. Now, this is something that I'm very proud of. The data that we will be presenting, it comes from 7 databases. These databases, some of them come from Europe, some of them come from the United States, and they have been averaged, and I think this constitutes really a very sound database. None of these studies use contrast, so all of the data come from non-contrast studies. We know from every patient, of course, the age, the gender, the ethnicity, the height, and the weight. And interestingly, none of these patients had elevated blood pressure. They didn't have diabetes. They had normal BMIs, creatinine, glomerular filtration rates, and lipid levels. So that is, I think, pretty good as an understanding that the patients that were studied were relatively normal. So I am going to talk now about the left ventricle. And the first thing is that these guidelines take a very strong effort that things should be quantitated and that we should not use an eyeball in order to assess left ventricular function. We know that these parameters, when we do it by eyesight, are subjective, are very dependent upon the experience. They are not standardized, and as a result have large inter and intra-observer variability. For many of these parameters, I have put smileys or frownies in order to try and tell you a little bit what we think about this. And this, of course, is a smiley and a frowny at the same time. Now, when we obtained the ventricular measurements, we are now not longer recommending M mode and not even the targeted M mode to obtain these linear dimensions. And although these can be obtained, we are sort of recommending that these measurements be obtained from a two-dimensional echo, from a parasternal long axis view, and we understand that this measurement should be performed perpendicular to the long axis of the left ventricle, and these measurements should be performed at the tip of the mitral valve. So we have to avoid these oblique sections of the ventricle, and by imaging with 2D echo, I think that gives us the best type of opportunity. All in this manuscript, you're going to see obtained from these databases the 95% limits, and these are made in which you can have in one axis the body surface area, and in this example the end-systolic and end-diastolic dimension, and you can see that these values are slightly different for males and females. I'm not going to go over these numbers. You can download them and use them as you wish. And this is one of the parameters in which we are, yes, providing cutoff values for normal, mildly, moderately, and severely dilated. These dimension measurements should be done taking into consideration the gender and, of course, the body surface area. Regarding the volumetric measurements, these, of course, can be obtained from either linear measurements, from 2D echo, or from 3D echo. We now, the committee comes strongly from the point of view that when you want to obtain volumes for linear measurements, that should not be performed. So calculation of volumes using the Teichel's formula or the Quinones methods for calculating every volumes from these linear dimensions are not longer recommended. And the main reason for that is that they rely on the assumption of a fixed geometric LV shape, such as a prolate ellipsoid, which of course you understand does not apply in a variety of cardiac pathologies. Left ventricular volumetric methods, as we all do in most of our labs, should be performed with a biplane disc summation method. We have to be, of course, very careful to avoid foreshortening. This method corrects for shape distortion. It assumes less geometrical assumptions compared to a linear dimension. And where we go wrong is when we foreshorten the apex, and many times on the apicolateral wall we can have endocardial dropout. The other method that is recommended, though less strongly, is the area length method, in which we need to measure a long axis of the left ventricle. So in those type of situations in which you don't see the endocardial tracing of the apex, you only need to have one point to do that, and then you need to get the area in a short axis. Again, we want to make these tracings in between the trabecula and the compacted myocardium. And here we see again the left ventricular volumes by two-dimensional echo, and these you can see if you take in one of the axes, you can see age. On the other axis, you see the left ventricular end systolic or end diastolic volume already taking into account the body surface area. You can see that these volumes are different between genders, and you can see that there is a slight decrease in the volume as we all age. And here again, you can see both the 95% confidence limit and also the volumes that have been calculated with the standard deviation. So if you look at the volumes, this is again a parameter in which we provide all of these cutoff values. And again, the diastolic volume should be measured according to gender and taking body surface area into account. These numbers, of course, are slightly different to the measurements provided in the previous document. Now, regarding three-dimensional echo, we have all talked a lot about what are the potential advantages of left ventricular volume. The biggest advantages being that you avoid foreshortens, and you're less reliable on a geometrical shape. And here are the normal values. This is one parameter in 3D in which we feel comfortable that there is enough data in the literature that we can provide cutoff values for both men and women. And you can see that these numbers are slightly larger as we would expect to the two-dimensional numbers. And these numbers are slightly lower than the normal values of cardiac MRI. And we recommend that in laboratories that have experience in 3D echo, 3D measurements and reporting of LV volumes is recommended when feasible, depending on image quality. Well, this is a good and a bad sentence because the only way you can get experience is if you try to do that. Now, regarding left ventricular ejection fraction, we all have an opinion of the good and the bad. We know it's a measure of overall left ventricular performance. We know that it's dependent on loading conditions, but this is the parameter in which we all actually communicate regarding left ventricular function. And I would put this two smileys. We have a slight change in left ventricular ejection fraction from the 2005 to the 2015 guidelines. And you can see that now our normal values are slightly lower. 52 is the normal cutoff value. And if you would like to remember a number, its ejection fraction is 63 plus minus 5. So you take two standard deviations. So on the upper it's 73, on the lower image it would be 52, 53. So a normal person over the age of 18 should have an ejection fraction within those limits. These are the new cutoff values. And another thing that is new in these guidelines is that that the ejection fraction are different between males and females. And women are, of course, superior and have a higher ejection fractions than males. And this is also something that should be taken into consideration. So changes here. We are talking about gender differences, and the numbers are slightly lower than the numbers that were previously reported. Another way that we all measure function is by using a strain, which, as you all know, is the deformation of a certain wall, if you talk about the heart, in a certain direction relative to its initial length. And this has become, as we all know, very popular in cardio-oncology to assess valvular regurgitation and low-flow aortic stenosis. In order to avoid variability in strain, it's always important to decrease the sector, to increase the frame rate. It's, I think, also very important that we avoid foreshortening. I think it's also very important to remember that if you look at the literature, there are many different ways of measuring longitudinal strain. You can do it at the endocardial level. You can do it at the level of the mid-wall, or you can do an average across the wall. The preponderance of the data that exists on the literature is by measuring strain in the mid-wall. So we recommend that this should be done in the apical long axis first to be able to define the left ventricular ejection time from opening to closure of the aortic valve or with clicks, and then to be done in the apical 2 and also in the apical 4, and these values should be averaged. The committee also recommends that if there are 2 or more segments in which you cannot get a good trace, that you should drop the longitudinal strain and use another number. Now, this is now with just one sentence, but it took a long time. Peak global longitudinal strain in the range of minus 20% is what can be expected in a healthy person. I think it's also important to know that we have inter-vendor and inter-software variability, as well as this parameter can be, of course, age and load dependent. So if you want to do serial assessment of global longitudinal strain in one patient, we recommend that that be performed by the same vendor's equipment and by the same software. There is a lot of work between the ASC and the EACVI about trying to standardize industry, so we will refer to their work, and hopefully things will become simpler in the future. Regarding the segmentation of the ventricle, there are no changes compared to the previous manuscript. I think it's important to understand that the committee is not recommended the use of regional strain, because that is extremely variable. And when we look at wall motion for a wall stress, we are now just giving a 4-point score, of 1 being normal or hyperkinetic, 2 is hypokinetic, 3 is akinetic, and 4 is dyskinetic. We're taking away the number 5 for aneurysms, because an aneurysm is a focal distended systolic thickening that has a dyskinetic motion pattern. So we are eliminating the position number 5. Regarding the perfusion territories, there is only a minor change compared to the previous document, and this, of course, can serve as a rough guide when we interpret stress testing, understanding that the coronary anatomy is extremely variable. So now there is a question here for you to keep you awake. So which of the following is not a cause of left atrial enlargement? So you need to try and answer. Okay, and you get some time to do that, and then we will do the polls of this. Okay, and we can see which labs are answering incorrectly, so we'll get back to you very quickly. Just kidding. Okay, so tricuspid valve disease was the correct answer and was answered by 80% of you. So I will go on here. The correct answer is tricuspid valve disease, and we will go on. So now we're going to talk a little bit about the left atrium, which is very controversial. You all understand that left atrial volume has a very huge prognosticator of outcomes, and we all understand that increase in left atrial volume means increase in wall tension secondary to an increase in pressure in the left atrium. And we know that when the left atrium is enlarged, that means that there is chronic pressure elevation, but in order to understand the current filling pressures, we need Doppler echocardiography to do that. And this is a nice way of displaying this, is that if you have you can have two balloons, as you see on the panel to your right, that have the same size, but they're, of course, at different pressure. On the other hand, you can have two balloons that have the same pressure but are at different size. And this is a nice way to show these types of concepts. Regarding the measurement of the left atrium, we strongly recommend that the anteroposterior diameter measured on M mode should not be performed again. And the main reason is that when the left atrium remodels and enlarges, it does not do this symmetrically. So these, which is the way in which we did it for years and years, is not more recommended, not only recommended, but discouraged. I think another very important concept is in this slide is that the long axis of the left atrium and the long axis of the left ventricle are not parallel. So that if you obtain a non-foreshortened image of the left ventricle and you use that same image to measure the left atrium is going to be foreshortened. So this guidelines recommends the acquisition of dedicated views. This is the same patient. Look at the size of the left atrium in these two images. Dedicated acquisitions of the left atrium in order to measure volumes accurately. There are two methods that we recommend, either the biplane Simpson's rule method, in which we trace the endocardium excluding the pulmonic vein and the left atrium. The base of this is the hinge points of the mitral valve. You should not make the mistake of going up and following the mitral valve to incorporate the tenting. That would be the biplane Simpson's rule. A very frequently asked question is, do we need to do this in two views? And the answer is yes. If you calculate this, the volumes of the left atrium in the apical 4 and the apical 2 are not exactly the same. And if you do it and measure it in one, you're assuming that the left atrium at its mid-level has a shape that is a circle. We also can use the biplane area length method, in which you estimate the area in these two views and then the length, and the smallest or shortest length is used. And then, of course, we have three-dimensional echo, which would be the best way to do it, but we do not have reliable data. We don't have enough normative data, so we cannot recommend 3D volumes at this particular point. Let me just tell you that when we provided the normal values of the left, before I say that, it's important also to know that if you calculate the LA volumes in the biplane Simpsons or using the area length, you don't get the same result. And these two methods differ by almost 3.6 mL. In the previous guidelines, and this is probably the one that gets the Oscars here, is in the previous guidelines, all of these data were obtained from only two published studies. And these were mostly measured using the area length method. Since then, there are 8 new studies that look at the normal values of the left atrium, and then we have all of the data of the databases. So in total, there's around 3,000 patients. And this is one in which, in the previous guidelines, we got it wrong. And these are the numbers that we used to provide. And you'll see that in these current guidelines, the numbers are much larger. On the top, you have the 2005 numbers, and on the bottom, you have the 2015 numbers. And you can see that there is a large increase in volumes. And, how we deal with this? Well, we just have to explain patients that had previously enlarged atria, that the normal values that were referred were wrong. But I think that this is one of the huge, big changes of this new guidelines. So another question, which of the following is not a method for measuring left atrial volume? So I'm going to let you read this, and then we will see what is the correct answer. The people here in my lab already answered correctly. Okay, so ellipsoid model using 3 linear measurements is the correct answer. That this was more difficult, 42%. You need to read the manuscript. That these 3 linear measurements are incorrect in the point of view that they're very dependent on a certain shape. So, regarding left ventricular mass, there are not many big changes from the previous manuscript. Let me just tell you that a linear measurement or the cube method to measure M mode is probably still useful when we need to screen or study a large population. It is advantageous because it is simple, quick, and subject to less measurement variability. The 2D method has the advantage that it can accommodate for the shape of the left ventricle and account for changes in left ventricular size that might occur along the long axis of the chamber. Regarding 3D, this would be the only technique that measures myocardial volumes directly without any assumptions regarding the shape of the ventricle, and also allows for the different distribution of wall thickening, like distal upper septal thickening. Unfortunately, we have limited normal limits for, there are a lot of studies that have validated LV mass with 3D, but very few studies that provide the normal limits of 3 echocardiographic left ventricular mass. So therefore, we are unable to provide you with a recommendation for reference values. When you look at the cubed formula values and you looked at the 2D formula, the area length of the truncated ellipsoid, 2D has slightly lower values. So if you take a patient, you cannot sort of compare using the cube formula and then use the 2D formula on another time, because these are not interchangeable. So we talked about 3D, and this is the same as in the previous. We talk about the different types of remodeling of the ventricle, normal geometry, eccentric, concentric, and concentric remodeling, and this is a relationship between relative wall thickness and left ventricular mass index. And the left ventricular, the relative wall thickness is 2 times the thickness of the posterior wall or the septum divided by the left ventricular internal dimension at end diastole. Regarding the aorta, there is a major renaissance, and everybody wants to measure the aortic annulus now that TAVR has come. And I think one of the important things that we need to understand is that the aortic annulus, hereby depicted as the green circle, is a virtual ring that is made by conjoining the nadir points, the green 3 dots of the 3 of the aortic cusps. So when we talk about the aortic annulus, the first important thing is that the aortic annulus should be measured in mid-systole. This is the time in which the annulus becomes rounder and more circular. And we use the inner to inner convention to measure the aortic annulus. Now, the big question is, where should we measure? And this is also something that has been now very nicely shown, that usually, and this is of course an MPR obtained from a 3D echo, we know that the aortic annulus can be measured from the parasternal long axis position in a transthoracic echo, or from an apical long in a 3D echo, usually between 90 and 120 degrees. And we would like to obtain these measurements between the right coronary cusp and this little nub here in between the left and non-coronary cusp. That is how we should be aligned. And if we are aligned in a long axis, we can see the right coronary cusp, but we are not going to see the hinge point of another coronary of another valve. This is when we are perfectly aligned. And I think it's important, if you look at a 3D echo or an MRI, 3D echo, of course, has the advantage that we can obtain exactly the correct position between the right and in between the non-coronary and left coronary cusp. And this shorter dimension or sagittal dimension should be the same between 3D echo and CT. A longer dimension is more mediolaterally, and you can see it goes from the right coronary cusp to the middle of the non-coronary cusp. 3D echo, of course, has the advantage that you can provide a short and a longer dimension of the annulus, and also we can provide information regarding the area and the perimeter. But I think it's important to remember inner to inner, mid-systole, and how we should be correctly aligned. When we, on the other hand, measure the sinuses of Valsalva, the sinotubular junction, or the ascending aorta, all of these measurements should be performed in end diastole. And here is something that is extremely controversial. The committee decided that these three measurements should be performed differently to what you do with MRI and with CT, in which they use the inner-to-inner convention. We are saying that we should measure from this outer point to this inner point here. And you can see that inner to inner is different if you would measure from this outer position here to this inner position here. And the main reason is that inner to inner and outer to inner is not exactly the same. The outer to inner is larger, and all of the parameters that show the cutoff values are used using this previous convention of measuring things from the outer to here to this inner side. And I think it's very important to understand that we did not want to change it, because all of these guidelines regarding when to operate on the aortic root are based on these measurements. If we change to inner, then these normative things, we should do something in the aortic root, gets to 4.5 or 5, would have to be changed. And I know that this is going to be very controversial. When we do the measurements of sinuses of Valsalva, these are measurements that usually have an impact on the dissection of the aorta and also on aortic valve regurgitation. Sinus of Valsalva usually does not change when you have hypertension. Only distal to the sinotubular junction appears to remodel. And these sinus of Valsalva measurements need change according to age and change according to body surface area. So we are recommending the use of these normative graphs in order to obtain normal values. In the document, we also provide cutoff values for the sinus of Valsalva. Well, now let's talk a little bit about the right ventricle and the right atrium. The right ventricle has, we all understand, a complex crescent shape. It is a very thin-walled and compliant chamber, which is very sensitive to afterload, and therefore it dilates and it can hypertrophy. And that is the main reason why we have to be very careful when we image the right ventricle. There are two views in addition to the apical four-chamber view. The focused apical four-chamber, which is in which we're going more lateral with the transducer and tilting the transducer. This is a view in which we want to obtain the maximal basal diameter of the right ventricle and the long axis of the right ventricle. And then we have the right ventricular modified apical four-chamber view with the transducer more on a lateral position And the objective of this view is to look at the right ventricular free wall in its entirety. So these are the three sort of views, and the reason why we image in these three views. Regarding linear dimensions of the right ventricle, we are predominantly now suggesting that the basal right ventricular linear dimension, which is the maximal transversal dimension of the ventricle, and we provide the normal measurement, which is 33 plus minus 4. And then we provide three other measurements, which is the proximal right ventricular outflow tract diameter obtained in the parasternal long or in the parasternal short, from the anterior wall to the RV, to this place where the septum conjoins the aorta, or where it goes to the aorta, and the distal, which is measured at the level of the pulmonic valve. We provide all the normal measurements. All of the measurements of the RV have also slightly changed compared to the RV document. Measurement of right ventricular wall thickness, usually made in the subcostal view at end diastole. This is performed below the tricuspid annulus at the distance that approximates usually the length of the anterior tricuspid valve leaflet. And the normal values for right ventricular wall thickness is 3 plus minus 1. Regarding right ventricular longitudinal systolic function, we recommend that at least two of these parameters should be considered for an echo report, and we have the measurement of TAPSE, which is done with an M mode, and you can see that this is a measure of right ventricular longitudinal function. It is measured by M mode with the cursor aligned along the direction of the lateral tricuspid annulus. And this, although this index predominantly, of course, reflects the longitudinal function of the right ventricle, it has very good correlations with parameters that estimate global right ventricular systolic function. The same would apply for the pulse tissue Doppler parameters. These are easy to measure, they are reliable, they're reproducible, and they correlate also well with other measures of global RV systolic function. It is important to understand that you want to be aligned with the Doppler cursor to avoid velocities underestimation. If you, of course, would use speckle tracking, that of course has advantages, but speckle tracking is influenced, as you all know, by image quality, by reverberation, and by other types of artifacts. And a new, very useful way, I think, is the use of global longitudinal right ventricular free wall strain. So with an emphasis on right ventricular free wall strain, here we don't measure the strain at the septal level. And we are providing normal sort of values for this right ventricular free strain of around minus 20%. There are two other indices of right ventricular global function, which are these indices of myocardial performance. These can be obtained by either pulse Doppler or by tissue Doppler, in which we want to do measurements of the isovolumic contraction and relaxation period and ejection time measured in 1 beat. For those of you who use this, please understand that the values derived by pulsed or tissue Doppler are not identical. And here are the normal values of right ventricular global function using this indice of myocardial perfusion. Regarding right ventricular linear dimensions and area, I think it's very important to understand, if you look at this particular graph, that right ventricular linear dimensions and areas can vary widely in the same patients with minor rotations of the transducer position. And you can see that very nicely here. That's why sometimes very difficult to obtain reliable, reproducible measurements of right ventricular area and fractional area change. So we provide normal values for this right ventricular area parameter, understanding that you have to be very technically correct in order to understand. And again, trabeculations, papillary muscles, and the moderator band are included within the cavity area. The use of three-dimensional echo for the estimations of right ventricular ejection fraction, in my opinion, are of particularly clinical value in patients after cardiac surgery, when you don't have a lot of a dysynergic septal shift. After surgery, these conventional indices that measure RV function like TAPSE or the S-wave are generally reduced and no longer represent overall right ventricular systolic performance. So this is a way in which right ventricular volumes and ejection fraction can come into play. These are sometimes very dependent on the quality and the experience, and we're going to see some new software coming out that are going to make things slightly easier. That we provide, yes, for the right ventricle, normative values for right ventricular volumes and ejection fraction, and you can see that these are, again, divided according to gender and body surface area. We also provide information regarding right ventricular segmentation and perfusion, and if you look at this graph, you see that the right ventricular free wall is usually getting blood supply from the acute marginal branch of the right coronary artery. And again, a parameter that we usually, I think, don't measure consistently in our labs is the right atrial linear dimensions, so the minor and major axis of the right atrium, as well as the right atrial volume. And we have now data to substantiate the volumes, again, by meter squared, are different according to gender. Differently to the left atrium, the right atrial measurements are only performed in the apical four-chamber view because we don't obtain a consistent right atrium from a two-chamber view. The IVC, of course, measured with a patient lying down, and this, of course, should be measured in expiration, and it should be measured 1 to 2 centimeters from the right atrial junction, measuring the dimension and the collapsibility index, and these are the numbers, and you can see these numbers when you download these slides or the document. So I would strongly recommend you to look at these guidelines and incorporate them into your daily routine as you see fit. Let me tell you that ASC has made two beautiful posters that have all of these numbers that I have talked about, and there is also an app phone that even has been updated even today with all these new numbers that you can buy for the iPhone and for the Android phone. I make really good advertisement here. For the IASC app that you can buy from your phone for really relatively very cheap price. I think it's less than $5. So I would like to, at this point in time, thank you all for hearing this dry talk about normal numbers, and I am going to attempt to answer some of the questions. Okay, so I have 2 trillion questions. So we are going to, let me see a little, Matt. Let me just say, one of the questions that I see is, what do we tell patients that we told them that the left atrium was enlarged and now it is normal? So one of the things is good news. Your atrium now is better than it was before. But I think we need to explain a little bit that the normal values were maybe slightly incorrectly obtained. Well, thank you for all the people who say that they like this. So somebody, right atrium and right ventricular numbers for qualitative, not quantitative way. So again, we would like very much to have people incorporate as much quantitation as you can in a echo read. And I think that for the right ventricle, you need to have at least a measure of dimension and 1 or 2 measures of performance. And I think with that, we already would be doing pretty good. Another question, can you use 2D linear dimensions as opposed to M-mode used in LV size measurement and the cube formula for LV mass? Yes, of course, you can do this. These linear dimensions can be obtained from you can obtain those from a 2D targeted M-mode or preferably from a 2D, because I think it allows you to align this image better. How long does post-surgical septal wall motions last? They usually last for quite a long time. I have never really looked at that and would not know how to answer. On table 14, aortic root dimensions in normal adults in the guidelines, why are the index values for women larger than the index values for men? I will maybe write me an email about that when I have to look at it. I don't have that document. Then it says, can you show the TAPSE method one more time? Well, the TAPSE method is what we use is M-mode, and you use M-mode from the lateral annulus. You have to be aligned because you're measured longitudinally, and that's something that is very well described, and I think it works most of the time. I think you have to be a little bit careful when you have a lot of TR, because I think it can provide you maybe with a false number. We use 2.1 as the upper limit for IVC measurement. So there is a discordance between the previous RV guidelines and these guidelines, and I'm not telling you what to do, but I think we all agree with these numbers as the numbers that we're going to go with. So I think I would recommend you go with the numbers that we have now. RV acquisition, any recommended view? So yeah, this is a very interesting question, and I would recommend that most of the basal measurements of the right ventricle performed in the RV focus view. I think the other view is good to look at the RV free wall, but you should not make measurements because the right ventricle is distorted. And to do these measurements of linear, you want to make sure that you are aligned so that you can, the right ventricle is going up and down to get the accurate way. So that is a little bit different. Why the change from RA area to RA volume? Only using the 4-chamber view, that is a good point, because essentially you're just transforming an area into a volume. This is what most of these databases provided us, was using the RV volume, but that is a good point. Well, it is already, let me see if can you please define a dedicated view for LA volume measurement? Okay, so that is a good point, and we are sort of working with that a lot here, is that you would want to obtain two different views. You want to obtain an apical 4 maximized for the long axis of the left ventricle, and then you want to do the same thing from the left atrium, and many times I tell the sonographers to do it without even looking at the LV. So you want to maximize the size of the left atrium so that you can obtain the maximal non-foreshortened view of the left atrium. So that would be a dedicated view of the left atrium. You should try it, and you'll see that it will work for you, and I think you'll get the most accurate LA measurements. How can we break the vicious cycle of not using 3D because there is no data? There is no data and not having data because we almost don't use 3D. Well, that's a very good question, and I think that now this is more of a personal opinion. 3D transducers need to further improve. I think that 3D needs to become much more automated in order to do that, and then that will make us use it. 3D echo TEE is very useful. We all use it. And transthoracic has to improve to make us all use it. And if you look at this data, and I'm sort of positively biased, if you look at this data, there's only reliable normative data for the left ventricle and pushing it for the right ventricle. And other than that, all the rest will have to wait another 10 years for the next guidelines that for sure I will not be writing. So I think with that, there are many more questions. I'm going to look at them, and I have your email address. So if there is something that I think is something that is not really in the document, I will try and answer. Another one that is interestingly, which was the question number one that was written even before I start talking, was how to measure left atrial mass when you have a sigmoid septum. And I would answer you that the only way to measure LV mass in that type of situation would be using a three-dimensional method. Because if not, the other ones, you're assuming so many things that you'll get a very inaccurate way. So 3D, of course, overcomes this. The problem is, as I said, that we don't have any normative data for that. And with that, I would really thank everybody.